Hello? Hello? Alright. Okay, so today's lecture is delivered to you probably in the past, and it's a different one because it's pre-recorded. And before I begin, I'd like to thank first my moderator, who is Adrian. Thank you so much. And of course your school for allowing me to provide this particular lecture for you guys. So today's topic is of course peripheral blood smear examination. This is one of the key important topics that you need to understand. Yeah, I'm starting already. All right. Yeah. Hang on a sec. Yeah. Yeah, I'm starting. You can check the YouTube live for our to monitor it. All right, thank you. So, before we begin, I'd like to start first with a little bit of disclaimer. Most of the pictures here are have been collected from my own personal archive of photos, and if I used some images from the internet, I will cite down the references. Okay, so yeah, we're live. Thank you so much. All right, so those are our disclaimers for today. So we can begin. All right, thank you so much. All right, and now when we view cells in the microscope, a technologist should be aware of the following cellular characteristics, of course. This will come in handy later on when we're identifying what type of morphological abnormality or anomaly is expected. So we're going to start first with RBCs in this particular lecture, and then we're going to build up to inclusions as well as WBC morphological abnormalities. Okay? Now, let's move on to the answer to this question. It's cell size, the characteristic of the nucleus, and the characteristic of the cytoplasm. So for RBCs, what we're looking for is cell size and the characteristic of the cytoplasm. Okay? Next. When viewing the peripheral blood smear, it is important to note certain variations from the norm, like 5 things. We need to note the alteration of RBC distribution, of course, variation of cell size, variation of shape of the cells, of the shape of the cells, alteration in the color, and inclusion bodies. So these are things that are important for us to understand. So just a brief overview. We're going to talk about distribution. How are the cells arranged? Okay. The size of the cell. This is known as anisocytosis. Variation in shape is termed as poikilocytosis, and alteration in color is primarily either with hypochromia or hyperchromia, or sometimes we would call alteration in colors in WBCs, like for example flame cells, all right, which are basically plasma cells that are not basophilic in nature, but rather they are eosinophilic in nature. So these are things that you need to take into consideration. Inclusion bodies, you could say Howell-Jolly bodies. Other notable inclusion bodies can be parasites. So those are the things that we need to take into consideration when we're looking at blood smears. Okay. Now, in terms of taking the ASCPI examinations, this particular presentation that you're going to see is extremely important, mainly because you will get questions like identify the cell. So you must be able to either identify the cell or identify the abnormality. You'll get questions like these. All right. Sometimes they will show you pictures. They will show you a picture of a general blood smear, and then you just need to tick the boxes. What are the cells that are abnormal? What cells do you see here that are abnormal? You can probably see drepanocytes. You could see inclusion bodies, and more often than not, it's not just one it's not just one peripheral blood smear picture. You would see one abnormality in one peripheral blood smear picture. You'll see multiple. You will see in the coming slides. You'll see multiple abnormalities in the cell. And whilst you're looking at it in the microscope in actual practice, you'll take into consideration these types of alteration from the norms. Now let's go to alteration in RBC distribution. How the cells are arranged in the peripheral blood smear. So the first part of the first part of what we're going to look at is the part of the blood smear first. What particular part of the blood smear is observed? This is a question that I always pose for trainees as well as interns who come into the hematology laboratory under my tutelage. Okay, usually we will start first by asking this initial question when I'm training the students. Why? Because they must not differ from the standard. This is standard. An ideal blood smear should have what? A feathery edge, and therefore that's because the reason being is the analysis or observation of peripheral blood smear is done on the feathery end of the film, or what we call the corona. Okay, so if you made a, let me check first if I can make a drawing here. So for example, this is the smear that you made. Okay, the upper edge there will have some sort of feathering, and this is where you will point the objective of the microscope. Okay, there you will find in this particular box over here, this one area here, you're going to observe the cells. Other places can cause anomalous results, and therefore there would be inaccuracies in your findings. Okay? Why? There's artifactual findings here, which we will discuss later on. All right? Now, let's move on to distribution. What's the normal distribution of RBC like? So what's the normal distribution of RBCs? Hang on a sec. What happened? What happened to my slideshow? Oopsie. All right. So let's begin again. What should normal RBC distribution look like? So what does a normal RBC look like? Well, the RBC should have slight separation from the cells in the smear that you're looking at. If it's normal, should have separation but no overlaps. Okay, so that's the answer to this particular question, right? So the cells should be slightly separate from one another, slightly separate, but there shouldn't be any overlapping. If there's overlapping, it's considered as what we call rouleau formation. Okay, in terms of cellular distribution, what abnormalities is often seen? There's only two things that we need to look at, or we need to be familiar of: rouleau formation and agglutination. Why? Because there are certain disease states that causes these particular findings. Okay. Now, how do we briefly discuss rouleau formation? Rouleau formation is identified as having stacks of coins, okay, wherein there are no cellular outlines visible. Look closely at the smear, the example here. They are stacked together. They're on top of one another. The surrounding cells from the sides here, you can see the clear central pallor of a normocyte, or central pallor rather, of normocytes. But in the stacked cells, you would not be able to see it. All right? So that's one of the things that you need into consideration. If the cells are stained properly and they're not really in rouleau formation or in stacking formation, abnormal stacking formation, you would still see normal central pallor appearance. All right? And this characteristic is what is important for us to identify. Okay, there is rouleau formation in the patient's findings. All right. Now, we have to talk about the main reasons why this type of phenomenon occurs. And of course, this is reflective of the protein in the protein levels in the patient's serum. So again, we're going back to clinical chemistry, and we're going to return to the term hyperproteinemia. Okay, hyperproteinemia. Why? There's increased proteins in the blood, okay, in the plasma, and this causes the cells to become sticky. All right. Now, there are disease states that are associated with rouleau formation. We'll just go by them briefly: multiple myeloma, macroglobulinemia, and hyperfibrogenemia. Okay, multiple myeloma is a malignancy that is called, which is a myelodysplasia, which is a problem with the plasma cells. They are producing abnormally functioning antibodies, as well as abnormal structured antibodies. Macroglobulinemia is similar to multiple myeloma, but the malignant plasma cells are producing macroglobulins, which are IgM based abnormal antibodies. Okay, we have Waldenstrom's macroglobulinemia. Now, for hyperfibrogenemia, basically it's a formation of abnormal amounts of fibrinogen in the patient sample. Okay, and this can come from either pregnancy, tissue necrosis, several things. There's a plethora of sources of hyperfibrogenemia. Okay, so you must not be. I'm just stating it in general here. All right. Now, another abnormality in terms of cellular distribution is something that is called clumping or clustering of cells. Now, in clinical microscopy, particularly when we're viewing urine and semen samples, we just call them as clumping or clustering. All right, there's clumps, so we would often note as there are clumps of WBCs present in the patient's urine sample. There is agglutination. This is what we call agglutination when we look at it in the semen sample. Similar to that, RBCs have the same thing. Okay, this is a recent photo that I've collected and added to our laboratory archives. Okay, this is actually stained by me a couple of days ago, and you can clearly see that the cells are clumped together. All right, even the WBC sticks with the other cells as well, or the RBCs as well. So from what you can gather here, this is a clotted sample. And I wanted you guys to see it because sometimes clotting is not visible macroscopically. Sometimes it's what we call macroscopic agglutination. There's macroscopic clotting. Okay, so there's two types: the macroscopic and the microscopic. This is an example of a microscopic agglutination. How do I know it's a microscopic agglutination? I didn't visibly see it, but there is a flag on the automated analyzer that there is false decrease of RBC counts and false decrease of platelets. This will give me an indication that something happened in the cell. So when I made the smear, this is what we saw. All right, clotted samples. You can clearly see as well the platelets are also clumped there, meaning that they've been activated, and we're going to talk about them later when we move on to the topic of coagulation. All right, but for now, this is what you would see if the cell is agglutinated. Now, where would I see this? In the peripheral. Where would I see this? In the peripheral blood smear? You'll see this in the feathery edge. If you look at this, if you see this type of arrangement or cellular distribution on the upper portions of the smear, that means that it is normal. All right, because on the thicker portion of the smear, you will see things like these. But if it's in the feathery edge, there's got to be something wrong with your sample. Either it's clotted or it's actually been agglutinated. Now, we need to look at the main reasons for cellular agglutination. The presence of course, immunoglobulin. This is the clinical, in the clinical reasons of why cellular agglutination happens. All right. So there's the presence of immunoglobulins on the RBC surface, as well as the presence of adhesion molecules on either the WBCs or the platelets. Okay. Now, that's the answer to that. Okay. We're going to move on to agglutination causes based on technical errors, or pre-analytic causes of agglutinations in the blood film, which is of course not disease related. Cellular clots or microclots in the sample are present. You can correlate this with the automated analyzer by looking at the RBC count as well as the platelet count. There's a decreased count. We're going to check at the samples, and oftentimes the machines are the analyzers that we're using are often sophisticated enough to detect these flags, especially if it's done through impedance principle, which was discussed later, and also flow cytometry. Okay. EDTA-induced platelet satellitism is also included. Why? Because there are some patients who produce anti-EDTA antibodies, and in this case, there's no particular evidence to suggest why some people produce EDTA anti-EDTA antibodies which therefore results to platelet satellitism. But there's a certain way for us to correct the platelet satellitism, and it's also known, by the way, this is also known as EDTA-induced platelet satellitism is also known as pseudothrombocytopenia. Okay, and the corrective action for this one, when we see it in the blood smear, is running the patient sample recollecting the sample and running the patient sample with sodium citrated anticoagulated blood. Now, it could be any type of sodium citrate anticoagulated blood. It could be the one that we use for ESR analysis, or it could be the one that we use for coagulation studies. Okay? But we need to do computations. If an automated analyzer was used on sodium citrate anticoagulated blood, we need to correct it by multiplying the platelet results to 1.1. Okay? So the platelet results need to be multiplied by 1.1. All right? Because why? There is dilutional effect. What do you mean by dilutional effect? EDTA is especially EDTA nowadays is mass produced in crystal form. Therefore, there's no dilutional factor, and the amount is so small that it doesn't necessarily cause a dilutional effect. But a lot of sodium citrate, as well for ESR and coagulation studies, oftentimes have liquid-based anticoagulants, and therefore we need to take into consideration what will happen to the sample. And of course, one of those things that we need to take note of is dilutional effect of citrate, because they are liquid. Mixing liquids together causes dilution. One is the solvent, one is the solute, and in this case, the solute is the sample itself, right? That's why we need to factor in that particular part of the sample. All right. Now let's move on to the most common cause of autoagglutination when preparing blood films. Autoagglutination From the name itself, we are going to talk about cold agglutinin disease or cold agglutinin. Cold agglutinin disease stems from what type of bacterial infection? Just a review for bacteriology. Yes, mycoplasma. So for mycoplasma. All right. Okay. Now, I'm gonna go and push through to the next couple of slides because this has already been discussed in microbiology. Now we're going to move on with the corrective action. When we think that there is autoagglutination or cold-induced autoagglutination, we need to pre-warm the blood. Okay, we need to pre-warm the blood, of course, and the slide before preparing the patient blood film. All right. Now, cold-induced agglutination usually occurs at 31 degrees Celsius. Okay, so anything above 31 degrees Celsius is considered as pre-warming. So in the laboratory that I work in, we would often detect these types of disorders, and we would oftentimes have patients with these types of conditions. And what we do is we just send the samples to the incubators in blood bank for a couple of minutes. We just put it there in the blood warm. We just put it in the blood warmers there in. We just put the blood warmers in the sample. We just put the sample in the blood warmer for a couple of minutes just to incubate it. And then we run the sample again. And usually it would correct autoagglutination. But one person needs to put the slide. If we're going to prepare it for the smear analysis, the slides also need to be pre-warmed. Okay? Usually at 37 degrees Celsius. Now, I mentioned this question before, the variation of cell size. Okay, the terminology, the correct medical terminology is, of course, anisocytosis. Okay, anisocytosis. Variation in cell size is known as anisocytosis. What RBC index is, of course, important when we measure the degree of anisocytosis. Of course, we're going to look at the volume of the cell, and when we look at the volume of each red blood cell, we are looking at the mean corpuscular volume, or the MCV. Okay, mean corpuscular volume, or the MCV. And when observing the cells for anisocytosis, what important findings should the technologist take note of? Of course, we are looking at either when we're looking at the degree of anisocytosis, we look at MCV, and when we look at MCV, we need to take note: is it microcytic or is it macrocytic? That is the question. All right. So that is the question: is it microcytic or is it macrocytic? What do we consider as cells as macrocytic? I'll give you a couple of minutes. Macrocytic cells will have an MCV of greater than 1 minute. 1 minute. I'll put a timer on 1 minute. For those people who are... Alright, so my moderator said that my audio is low. Hello? Okay. So, can you hear me now? Let me adjust a couple of settings in my computer so that we can increase the volume of my voice. Hello? Let me check first. All right, so I think we're fine now. I just got a message. I checked it out on my own phone that audio is back. So what was the question that was asked again? Macrocytosis. Yeah, so macrocytosis. All right, so for macrocytosis, we are going to look at the MCV. MCV greater than 100. Microcytosis, MCV less than 80. Okay? Femtoliters, of course. All right. Now we're going to move on to the next slide. And how is a red cell identified as macrocytic? Now, in this slide, when in the perspective of a slide, if you want to be technical, it's a cell that is greater than 9 micrometers. All right. It's a cell. It's any RBC that reaches greater than 9 micrometers. That's considered as a macrocytic cell. All right. So in the perspective of slides, if we're not looking at the automated analyzers reports, okay. But usually in actual practice, you'll see this. Okay, MCV is above 100. All right. Let me check in the slide. Yeah, they're a bit larger than normal. So more often than not, practitioners would ignore the actual measurements in the microscope, because not a lot of microscopes today have graduations or measurement rulers inside, provided in the slide or in the objectives. Okay, so yeah, MCV is still the best. But again, confirmation in this slide is still important, as ever since, of course, just to confirm what the analyzer just saw in the machine, saw in the sample. All right. So what are the possible reasons for microcytosis? Well, basically there are 3 mechanisms. It's increased through impaired DNA synthesis, accelerated erythropoiesis, or increased membrane or cholesterol, membrane cholesterol and lecithin levels. All right, so those are the things that we need to take into consideration as well. Now, the most common cause of microcytosis, when we're talking about disease states, so these are mechanisms. All right, possible reasons. Means we're talking about the mechanisms. So DNA synthesis, impaired DNA synthesis, accelerated erythropoiesis, increased membrane cholesterol and lecithin. Okay, so the surface of the cells are affected in the last one. Now we move on to the most common causes of macrocytosis. Now macrocytosis is of course caused by vitamin D deficiency, particularly 2 vitamins, which we will discuss later: hyperthyroidism, liver disease, and of course drugs. Now, what vitamins causes macrocytosis? What vitamin deficiency causes macrocytosis is vitamin B12 and folate. We've discussed this when we talked about anemia, so I'm not going to delve deeper into this, because this is basically this is a review class only. All right. Okay, but basically vitamin B12 allows the cell to do allows the cell to perform cellular division. That's the basic gist of it. All right. So drugs that causes macrocytosis are the following: methotrexate, okay, cyclophosphamide, nitrous oxide, and arsenic. Arsenic, sir? That's weird. What's arsenic used for? It's actually arsenic trioxide. It could be used in the industry when we're making certain inorganic, when we're reacting arsenic with different metals to produce different metals. But in medicine, they use arsenic trioxide actually as a treatment for acute myeloid leukemia. Okay? And nitrous oxide is, of course, your general anesthetic. Okay? And these two as well are considered as what do you call this? These two are considered as chemotherapy drugs. Okay? Or the first two rather. Now, what is the average diameter of a microcyte? A microcyte, again, this is an RBC that is less than 6 to 7 micrometers. It's not point, sorry. I made a mistake in that one. It's 6 to 7 micrometers. It's less than 6 to 7 micrometers. Now, common cause of microcytosis is, of course, impaired hemoglobin synthesis. There's just one cause, impaired hemoglobin synthesis. So it's easy, guys, right? So for macrocytosis, there's a lot. DNA synthesis, just a review, guys. Impaired DNA synthesis. All right, we're going to go back to that slide again, just for your information. DNA synthesis, accelerated erythropoiesis, and increased membrane, cholesterol, and lecithin. All right, so the surface of the cells are the problem. In this case, what's inside is the problem, and basically it's the hemoglobin synthesis. Now, there are 3 clinical conditions that causes absolute microcytosis. This means when we say absolute microcytosis rather, when we say absolute microcytosis, most of the cells, or 90% of the cells are microcytes, meaning they're small, meaning they're less than 6 to 7 micrometers. This is iron deficiency anemia, thalassemia, and anemia of chronic disease. Really? Yes, really. These are the only diseases or disease states wherein you'll see microcytosis 90% of the time. All right. Now, partial microcytosis. What is this term, sir? Partial microcytosis. What's that? Well, basically, when we say absolute microcytosis, 90% or 100% of the RBCs that you're going to see in the peripheral blood smear is characterized by microcytes. While for partial microcytosis, it's going to be around 70%, 50 to 70% microcytes. Okay, you'll still see some normocytes here and there, and usually this is caused by poisoning, specifically lead poisoning, and of course iron loading anemias. What is the example of an iron loading anemia? Sideroblastic anemia. Why? What's the problem in sideroblastic anemia? There's a problem with hepcidin. Hepcidin prevents the exit of ferritin to the peripheral blood. Okay? So hepcidin is the problem with sideroblastic anemia. But again, sideroblastic anemia is just one of the many iron-loading anemias out there. Now, we need to take note of the following first. Note, it may not be seen by the analyzer. Partial microcytosis is not usually detected by the analyzer unless it's severe lead poisoning, okay, or severe sideroblastic anemia. Okay, so here the problem is detected when the blood sample is looked at in the microscope. So you see the importance of looking at the samples in the microscope. So I think it would still take a couple of centuries for automation to catch up to human intervention. So looking at the microscopes, looking at the slide rather, is still an important factor in our practice. So we still have an edge over my machines. Okay? Now, variation in shape is known as poikilocytosis, and this is something that we're going to take a long time discussing. All right? So poikilocytosis is variation in shape, and the first shape variation that we're going to look at is a codocyte. A codocyte is termed as what? A target cell. Another term is Mexican hat cells, right? Now, look closely at the sample that I've provided for you guys. This is taken from This is taken from, I think, Central Texas University or college. Yeah. I forgot to put in the what do we call this? I forgot to put in the patient I forgot to put in the credits. This is not from me. This is from a public domain, which I don't think would be copyrighted. But yeah, for this reason, that's the reason why I'm citing out the source. But this is from the Central Texas College. So look at the samples carefully. The central pallor is not visible. The central pallor has a central dark shade of darkness there. Okay, so it looks like a target, a bullseye, obviously. Now, through circulating forms of podocytes, when we have an electron micrograph of the cells, they would look extremely different. They would look bell-shaped. And what causes them to form target cells in the blood smear is actually air drying. All right. So when you look at this, in actuality, these cells are bell-shaped. Okay. But when you're using a light microscope, and because of the smear drying, they would look like target cells. That's the basic explanation why they turn from bells to target cells. Okay. Now, the main mechanism for podocyte formation, or the pathologic mechanism for the formation of podocytes, is the imbalance between hemoglobin and the lipids within the cells. Specifically, again, cholesterol and phospholipids. All right. So we're looking at two different aspects of the cell. What is the pathologic cause and what is the artifactual cause? So be mindful of the artifactual cause, because we're going to talk about it more in the upcoming discussion. All right. Now, what happens is there's less hemoglobin than that of the lipid content, which is cholesterol and phospholipid, as I mentioned before. And yeah, so there's an imbalance. Basically, there's an imbalance between hemoglobin and lipid. Okay, so hemoglobin is decreased, okay, whilst the lipids increase. Okay. Very simple. Now, based on RBC index, what general characteristic of smears with podocytes is always, the general characteristics of podocytes is always hypochromic. Why? Because for my previous discussion, hemoglobin is low. And with low hemoglobin, this is also synonymous to low MCH. Therefore, the cells would have a hypochromic presentation. So if you see podocytes and if it's normal in terms of chromicity, when I say chromicity, this is the color of the cell. We're going to discuss that also in subsequent discussions. But for now, all you need to know is that the RBC index of a podocyte is always going to be microcytic hypochromic. All right, microcytic hypochromic. Now, podocytes are always seen in the following conditions: sickle cell anemia and HBC disease. Specifically, what? Homozygous and heterozygous HBC. All right. So what's the difference between a homozygous and heterozygous? Homozygous, there is an abnormality on one side of the the abnormality, or the problem is that there's an abnormality on one side of the allele only. If it's heterozygous, it's on both sides of the allele, or both alleles. Now, target cells may be seen in the following conditions: IDA, liver disease, and of course, post-splenectomy conditions. All right? So post-splenectomy. Okay? IDA, liver disease, and after splenectomy. All right. Now, OFT results of codocytes are as follows. What's the OFT result of a codocyte then? Well, because of the increased lipid content, it would take them longer to explode. So therefore, it's going to be what? A decrease in OFT or an increase in OFT? I'll give you guys a minute. Think about it. Alright, 1 minute is up. The correct answer is decreased OFT. Why? Because there's more lipid protein. There's more membrane proteins. Membrane lipids. Okay? Than hemoglobin. Right. Good. Now, these are cells that have the lowest surface area to volume ratio. These cells are aptly known as spherocytes. And spherocytes are characterized as RBCs without a central pallor, the central pallor, and they have a similar size to normocytes. Okay, they have similar size to normocytes. Okay, so looking at them closely, these cells, they don't have central pallor, right? Usually they would usually a normal RBC would have some sort of what do you call this? It would have some sort of, where's my pointer? I want to have a pointer here. Oops. Laser pointer. Alright. I don't have a pointer, so let's just write on it. Oh yeah, I have a pointer now. So look at the central pallor. There's the absence of biconcavity. So the central pallor basically indicates that there is a biconcavity. Now, alright, so mechanism involved in the formation of spherocyte is as follows. An anomaly or an abnormality in sodium influx. Specifically in patients with hereditary spherocytosis, there are receptors in the cell that allow the entry of sodium ions in the RBCs. Okay, and when there's more sodium, the basic notion is that wherever sodium follows, water wherever sodium goes, water follows. And when there's increased water, these cells balloon up and they lose the biconcavity structure and they become spheres or globes. Okay? Abnormality in sodium influx is the answer to that question. So the common causes of spherocytosis. So we're not going to delve deep into this because there's also a specific discussion on it. You can review on the specifics, but hemolytic anemia is associated with it, specifically if the sodium receptors have been activated by immune complexes. Okay, so they tend to form spherocytes. Hereditary spherocytosis is going to be a given. Toxins, burns, and splenic states or splenic states. So hypersplenism or post-splenectomy operations. Okay, so those are the 5 common reasons why you would see spherocytes in your sample. Okay, now we'll look at the next slide. In the next slide, we're going to talk about egg-shaped or club-shaped RBCs. And obviously, this is pretty easy to answer. Why do I describe it? Why don't I just show the picture? Because in getting your PRC license, you have to take the Philippine board exams. And as of recording this video, the way the test has always been conducted is through a paper-based test. So it's a paper-based test, and therefore there would be no room for pictures. Otherwise, there would be a lot of test papers for students to answer. So the reason why I want to describe it to you guys before showing the picture is that you guys are before anything else, before you take your ASCP examination or any type of examination related to laboratory medicine, is you have the prerequisite is always going to be your PRC license. And without the PRC license, so therefore it's always important for me, it's imperative rather for me to describe it to you guys before moving on to actually seeing what the cells looks like. Okay, so what the cell look like is these. They look like eggs, right? They're also known as elliptocytes. Normally these cells would have different variations. They could be hyperchromic, they could be macrocytic, they could be normocytic in RBC indices in an automated analyzer. And oftentimes they would only be detected in the peripheral blood smear. Surprisingly enough, we have one patient who has this kind of condition, which is hereditary elliptocytosis. Unfortunately, his elliptocytosis was not detected until such time that the physicians found it strange that there's always a flag in the machine, but the results are always normal. But when we looked at when the hematology specialists in the laboratory looked at the patient's blood sample, they noted elliptocytes, and this is actually one of the archived pictures that was sent to me by my hematology head in the department. So you guys can see the cells this time. They still have they still have the central pallor. But what's funny about them is although they look normochromic, the shape is the abnormality, and hence the term poikilocytosis. All right. Now, mechanism involved in ovalocyte formation in vitro is still unknown, but the primary culprit or the theory is that it's associated with the reduction of ATP and 2,3-DPG. Okay, 2,3-DPG and ATP, the rapid reduction rather. Now we're going to look at another abnormality, which is Burr cells or echinocytes rather. We're going to talk about echinocytes because there's two types of echinocytes really, but what they're characterized as having uniform blunt spicules. All right. Uniform blunt spicules on the surface of the RBCs. Now let's look at these abnormalities in general. So look at it, uniform, which means that they have not really gone more or beyond. It's not, I don't know if I would go and measured it, but in general they look the spicules look like they're almost the same size as the other ones on the same cell, right? So these are known as echinocytes. Now we have what you call artifactual formation of echinocytes. This is known as crenated cells. If it's an actual artifactual formation, it's crenated cells. If it's a pathologic echinocytes or echinocytes that originate from a pathologic disorder. This is known as Burr cells. And usually this is associated with a disease. Burr cell formation is usually associated with gastric abnormalities, specifically bleeding ulcers, carcinomas, and peptic ulcers. But we need to take into consideration also urea-associated disorders such as uremia, of course, and pyruvate kinase. When do we expect uremia? Well, basically, if the patient has a problem with his kidneys or he has a bacterial infection, this is what we call hemolytic uremic syndrome. Okay, which is basically there's a lot of bacteria in the bloodstream that they produce a lot of urea as metabolites, and this causes the cell to form Burr cells. But again, as I mentioned before, Burr cells are pathologic in nature, and crenated cells are artifactual in nature. So what do I mean? When you look at it in the microscope, if you're not looking at the feathery edge, you're going to expect a lot of RBC abnormalities. So always look at the feathery edge. All right? Now, let's try to differentiate echinocytes from acanthocytes. Echinocytes are characterized as having uniform blunt spicules, all right? Whilst acanthocytes have irregular thorn-like projections. Let's add a hyphen to that one because it looks like the writing was wrong there. All right, so there's a hyphen there. Right, so thorn-like projections. Look at these things. They look like bilirubin crystals. If you remember your clinical microscopy classes, they would say ammonium biurate crystals are characterized as thorny apples. Basically, they have the same appearance. And what sets them apart is the irregular projections. There is no uniformity to it. It's like random. The cells are just randomly being stretched. And the organ that is most commonly affected if the patient has acanthocytes present is the liver. Its primary causes are what? Basically, they're primarily caused by liver cirrhosis. What else? Alcoholism. So when you look at the literature, they are always associated with liver. Acanthocytes are always associated with liver diseases. Okay, neonatal jaundice is another reason why we see acanthocytes in a baby's blood smear if that patient has jaundice. All right, now let's look at mouth-shaped cells. Another name for mouth-shaped cells, is stomatocytes. So stomatocytes are characterized as such. They look like mouths. They look like one is a sad face, one is a confused face, and one is laughing. Look at it. They really look like mouths. And I'll show you later, because again, this is caused by artifactual formation again. This is based on technicalities rather than actual disease states, which is the reason why I want my students to look at the feathery edge before looking at the thicker portion of the smears. All right. Now, disease states associated with of course stomatocytes is hereditary stomatocytosis, but there are several causes as well: alcoholism, cirrhosis, drugs, malignancy, and lead poisoning. Okay? So again, lead poisoning again, sir. Remember, I've mentioned before that each cell anomaly that we look at here will reflect, will not necessarily be just one RBC anomaly, but it could be different. There could be 5 RBC anomalies out there, or abnormal or poikilocytes out there. So it could be more than one. You could have acanthocytes plus echinocytes, or you could have ovalocytes plus echinocytes. So it could be a mixture of a lot of the things, of all the things that we've seen here. Okay, so these are the reasons: alcoholism, cirrhosis, drugs, and malignancy. Hereditary, of course, it's either hereditary spherocytosis or hereditary stomatocytosis. It could be either. You could see both of them in each of the disorders. Lead poisoning as well. All right. Next, let's move on to the drugs that causes stomatocyte formation. Well, again, these belong to a specific group of drugs if we study our pharmacology a little bit better. Phenothiazine and chlorpromazine, they are both considered as antipsychotics. And most of the time they would produce stomatocyte formation. Just for your information. Now, let's look at the key differences between artifactual stomatocytosis and pathophysiological stomatocytosis. This one is from our archives, and this one is taken from, again, labreview.com. I do not take full responsibility for this photo, so I don't want to be copyrighted. Okay. Now let's look at artifactual clearly. Artifactual stomatocytes have a clear central slit and central pallor, right? They have a central slit, while genuine pathologic stomatocytes are more or less shaded. Look at them closely. They have shadings there. They don't have a central pallor, as opposed to this one. There, it's very clear for me that okay, this one is actually stomatocytosis. This one is artifactual rather, but this one, it looks like it's been painted in, like there's a shade to it. So you gotta appreciate whether or not this one is pathologic or one is artifactual. All right, because when you dry the cells, sometimes they would form artifacts, and this is an artifactual RBC anomaly. Okay, now let's look at poikilocytes associated to trauma. There's only two: helmet cells and schistocytes. Obviously, when you hear the word trauma, you need to take into consideration helmet cells. Basically, these two things, they appear in cases of hemolytic anemia. What else? Trauma, like for example, accident, RTAs, patients who have suffered from accidents. You'd see these things. Anything that has compare it to me shaking a Coke bottle. That's basically the comparison that I can give you guys. Like really, that's the like when I shake the contents of the Coke bottle, what happens inside is there's bubble formation, right? When there's bubble formation, and then that's basically what happens. There's the excitation of the contents of the human body, I suppose. All right, now let's move on to another abnormality, which is teardrops. Oh, why is there no picture here? I provided picture of helmet cells and schistocytes. All right, so I'll just add some of the links of helmet cells and schistocytes on the description box after this live stream, so you guys can just look at it. All right. So because I would be copyrighted if this video would not be available if I got copyrighted. So we want us to. I'll just provide the links for where you can see helmet cells and schistocytes on the description box. Now let's talk about teardrop cells and pear-shaped cells. This is what you call dacrocytes. Okay. Again, this is from lab.sciencereview.com, and this is what they look like. This one looks like a pear. This one looks like a balloon that has been slightly inflated, and you can see clearly that there's helmet cells here, or schistocytes rather. There's a schistocyte here and a helmet cell here. Okay, so there's also a target cell here. This one is an acanthocyte. So you can appreciate the thing that I said to you guys earlier here more clearly. Why? Because, as I mentioned before, you can't just see one RBC anomalies. In actual practice, you could see more than one anomaly. All right. Sometimes there could be an inclusion body thrown in there. All right. So you gotta be mindful of everything that you look at in the peripheral blood. Now, let's talk about the formation of dacrocytes involved. The formation of dacrocytes is involved because of what we call forceful stretching. So basically what happens is that they're being stretched to their limits, and the morphology of the cell is being affected as well. Now, when we talk about the next topic, where the thing that you need to take into consideration is abnormal hemoglobin content. So abnormal hemoglobin content basically means that there is an anomaly in the hemoglobin structure. All right. So can thalassemia be part of it? No, because in thalassemia, the globin structure of the hemoglobin the globin structure is still going to conform with the shape, and it does not polymerize the cell whenever there's oxidation rates. And I think you guys have an idea of what I'm talking about. Abnormal hemoglobin content. When there's abnormal hemoglobin content, the cells can polymerize. The cells can polymerize. When there's cellular polymerization of RBCs, it will form sort of like it will stretch out and form drepanocytes. These are what you call, commonly known as sickle cells. Okay? So drepanocytes. So look at these cells. So again, when you look at the smear, you can see target cells, codocytes, right? You can see schistocytes. And you can also see helmet cells here. See? So so again, the thing that we need to take into consideration is that RBC anomalies are sometimes thrown in a mixed bag. So we need to be mindful that not all that we've discussed here can be seen solely in one slide. They could be mixed in with one another. Codocytes. So see, looking at the cell, the peripheral blood as well, you can see spherocytes here also, right? The lack of central pallor, right? And what else can we see here? We can see that, what else can we see here? Slits also, there's stomatocytes as well. Okay? So those are the things that you guys need to take into consideration when we're talking about RBC anomalies. All right. Now, final thoughts on RBC anomalies before we go on with RBC shapes. Before we move on to inclusion bodies and abnormal WBC structures on our next discussion is that we need to go back to the basics. You need to understand the very first slide that we talked about earlier. As a medical technologist, what you need to look at is the cell characteristic. We're going to come back here. Sorry, I forgot to provide the hyperlink. You need to be aware of the cell size and the cellular cytoplasm, or the cytoplasm of the cell. Okay? And nucleus, when we talk about WBC anomalies, that's the time we need to take things into consideration. I forgot to mention also the what was that other one? I forgot to mention also the difference between a macrocyte and a megaloblast. A macrocyte is oftentimes caused by vitamin deficiency and vitamin B12 deficiency and folate deficiency, but most of the time it does not present itself as having hypersegmented neutrophils. While in megaloblastic anemia, you're going to see hypersegmented neutrophils, and in our next discussion, you're going to see hypersegmentation, hypersegmented neutrophils. Okay, so but that's it. That's it for me for today. in my general recording. I would like to again, this is going to be our next topic, and I'm going to share it to you guys on the next discussion. So for now, this is it for me, and have a nice day. Again, I would like to thank Adrian for moderating for this in this particular discussion, because none of this would be possible without the help of Mr. Adrian, and I appreciate his efforts in going beyond his duties for seminar. So thank you, Adrian, and thank you also for to your school for providing me with the platform to speak. Okay, bye for now.